This section of the neuro exam is going to include differentiation of the different types of headaches, primary and secondary, and of primary headaches, the difference between migraines, tension, cluster, and sinus headaches. At the end, I'll review a case study as well as the differentials, the actual diagnosis, and plan of treatment.
So we're going
to underlying cause, and it comprises 90 to 98% of all headaches. Secondary headaches are caused by a specific identifiable structural or physiologic pathology. Red flag differentials include stroke, meningeal irritation, facial and cervical involvement, systemic involvement, and trauma. SNOOP is an acronym used to report red flag findings. First, are there systemic symptoms? Does a patient have a fever? Are they vomiting? Neurologic signs and symptoms such as papilledema, cranial nerve palsies, muscle weakness. Was the onset abrupt or split second? Is this the worst headache of their life? Are they older? Is this a new onset headache, especially for adults over the age of 50? And then previous headache history. Is their first headache? Is this different from previous headaches or a change in the pattern of their headaches? When asking a person about their headaches, the 4 typical primary headaches are sinus, cluster, tension, and migraine headaches. Causes of tension headaches could be idiopathic, also could be caused by stress, anxiety, depression, disturbance on the serotonin system, cervical osteoarthritis, or contracted muscles of the scalp or neck, vasodilation. The causes are plentiful. A tension headache is most notable for its absence of migraine-like features. There's no pulsating sensation, no necessity to lie still in a dark, quiet room, and generally no history of migraines. People suffering from tension headache often do not stop what they're doing, noting that the headache is a nuisance but not incapacitating. If more severe, though, headaches can impair concentration, lessen the appetite, and make those affected irritable. During the physical exam, if the patient is not having a headache, there are no signs or symptoms. However, during the headache, you might note a furrowed brow, pallor, increased blood pressure, and muscle tightness and stiffness in the neck, frontal, and occipital regions. Many of the causes for migraine headaches are the same as for tension. However, with migraine headaches, a difference is family history and also the history of headaches as an adolescent or young adult. A migraine is actually a collection of symptoms that usually include a headache as the prominent complaint. It can also be called sick headache or weekend headache, and the headache is usually severe, unilateral, and in 1 out of 5 people will be accompanied by other symptoms. They're typically divided into headaches with aura or without. A common or classical migraine involves a sharp, throbbing headache on one side of the head from several hours to a few days and can be preceded by warning signs such as flashes of light or a visual aura. There are various triggers for migraines: dietary, hormonal, and also lifestyle. Stress, decreased sleep, and fatigue can often cause a migraine. Foods with tyramine are generally preserved or aged, and people should be aware of leftovers that have been in the refrigerator for more than 24 to 48 hours. The more aged foods become, the worse the trigger might be. Some examples of dangerously high levels are soy sauce, sauerkraut, and salami. Also, anything aged, dried, fermented, salted, smoked, or pickled. So watch out especially for pepperoni and liverwurst. On physical exam of a migraine, normally there will be no signs or symptoms if they're not having the headache. However, if they do come into the office with a headache, you might notice increased blood pressure, diaphoresis, irritability, vomiting, photophobia, and phonophobia. Cluster headaches involve frequent attacks of severe, short-lasting, one-sided head pain, typically behind or near the eye, that can last from a few minutes to several hours. Cluster headaches are rare, severe, and mainly affect men. A history of head trauma, heavy cigarette smoking, and heavy alcohol intake are all associated with the disease, although no causal relationship has been found. In fact, men that have stopped smoking have not found that the headaches are relieved. The three cardinal features of the disorder are trigeminal distribution of the pain, ipsilateral cranial autonomic symptoms, and circadian circannual pattern of attacks. Cluster headaches are always unilateral. They are orbital, supraorbital, and or temporal, always on the same side. They have a lot of associated symptoms accompanying them, and they're extraordinarily severe, also known as Horton's demon. People that have these headaches feel the need to move and seem agitated, and often are pacing the floor in an effort to feel better. On physical exam, a patient that's having a cluster headache might be seen pacing or restless, diaphoretic. You may see ptosis of one eye, an injective conjunctiva, constricted pupil, and they may resist being touched. Sinus headaches involve pressure or pain in the forehead, brow, below or behind the ear, behind the eye, and occasionally sensitivity in the upper gums. The pain is typically focused on one area and lasts until treated. Irritation can be secondary to infection of the sinuses by viruses, bacteria, fungi, or other organisms, or may be secondary to allergies. The pain tends to increase when the patient bends over, and people often will complain of tooth pain. Many people who assume they have sinus headaches actually have migraines or tension headaches. Studies have shown that 90% of those with sinus headaches actually have migraines. When documenting headaches, you'll be documenting a lot of positive negatives in an effort to rule out your differentials. This is an actual case study. I saw this patient at the Native American clinic, and she came in with headaches 4 to 5 times per month. Before seeing this patient, you go through your differentials, and in this case, headaches 4 to 5 times a month. The differentials are primary and secondary headaches. So it could be migraine with or without aura, cluster headache, tension headache, or sinus headache, or a secondary headache which could be potentially life-threatening, such as subarachnoid hemorrhage, bacterial meningitis, or brain tumors. When I walked into the room, I saw a young woman wearing traditional Arabic dress and head covering. She was non-English speaking, and her husband translated for her. She maintained good eye contact and was animated while gesturing to communicate. She appeared tired, pale, but denied night sweats, fever, changes in mood, or myalgias. The history of present illness include: she's a 36-year-old Arabic woman presenting with frequent headaches. She describes them as sharp throbbing on the right side of her head, 10 out of 10. She complains of photophobia and denies having any vision changes, flashing lights, muscle weakness, sensory changes, or loss of consciousness. She denies fever, seizures, falls, head injury, neck or facial pain, lacrimation, rhinorrhea, or a recent upper respiratory infection. Her medical history is significant for migraines 2 to 3 times per month that last 1 to 3 days. She reports that taking naproxen 500 milligrams by mouth and laying down in a dark room help a little bit. She states that her headaches are not predictable and she is unaware of triggers that preclude the headaches. She's worried that she may be having a stroke. Her past medical history revealed her last menstrual period was 2 weeks ago. She uses condoms for birth control. She has 1 child. She's not breastfeeding. She does have a history of migraine headaches, and she was treated with Paxil during pregnancy without relief. Prior to pregnancy, she was treated with Imitrex 50 milligrams as needed. She's had no surgeries or hospitalizations, but she does have a history of iron deficiency anemia. She's married. She moved to the U.S. 2 years ago, but speaks no English. She has no other family in the United States, and she is a non-smoker and denies alcohol or drug use. Her family history is unknown, and she said that the family doesn't talk about medical stuff. On physical exam, she's normal weight, vital signs were within normal limits, and she had no nystagmus, papilledema. Her face was symmetrical. Her temporal arteries were non-tender, because of course we are ruling out temporal arteritis also as a differential. There was no nuchal rigidity, so the Kernig and Brudzinski signs were negative. She has no focal or motor deficit, and rapid alternating movements, finger to nose function were intact. Deep tendon reflexes were 2+ symmetrical, and she was able to tandem walk without difficulty. We did a finger stick, and her hemoglobin was 11.6. So a little low, but not enough to cause a headache. The International Classification of Headache Disorders, 2nd edition system, presently provides the gold standard for diagnosis of migraine headaches. Migraine is the most common headache disorder seen by primary care providers. They are typically classified with or without aura. Most patients with migraines have exclusively attacks without aura. Many patients who have frequent attacks with aura also have attacks without aura. Based on the history and physical, my assessment was that she was having migraine headaches without aura. So the plan was to give abortive treatment, which means treatment at the time of headaches, by starting with sumatriptan or Imitrex 100 milligrams and naproxen 550 milligrams at the onset of a headache, and it could be repeated at 2 hours if the headache persists. She was educated to not skip meals, to ensure enough sleep, avoid dehydration, and to exercise regularly, and to avoid any known triggers, and to keep a diary to record information about the headache and associated triggers. We also gave written instruction about the medication. On follow-up, asked her to come back in 3 weeks to evaluate effectiveness of the treatment, or sooner if the headaches persisted in duration or severity. If more than 3 headaches a month, we would consider prophylactic treatment, which would include propranolol and amitriptyline.